I think it's work. Okay, here one. Okay, let's start. We got late, so it's a pleasure to me stay with you for this wonderful session about, I think, very rare bone sarcomas. And I will want to invite the speakers to the seat here with me. Bruna is coming. Just thank you. So, Bruna, come here with us. Welcome. The next speaker is Emanuela Palmerini. She was Italy and worked in the Riccioli, I pronounce it, Riccioli Institute, and she was more than 20 years ago learning about bone sarcoma. So, Emanuela,
thank you.
Welcome.
Yeah, thanks for the kind invitation and for Cellnet for this incredible network of people and knowledge. So I'm very glad to discuss with you about the multidisciplinary approach towards the treatment of condrosarcoma, localized and advanced. Condrosarcoma is a complex disease and has been reclassified several times. There are 4 grades, including grade 1, which is a benign tumor, and but it's locally aggressive, so it falls in the intermediate. And then we have the malignant that are the grade 2, 3, and the diff, defined by the possible presence of metastasis. There are several histotypes, but we will focus on conventional mainly, and a little bit on the diff. Symptoms are very important, as when there are no symptoms, you can watch and wait the patient, and of course, as Alberto discussed, the clinic. Histologically, they are very different, and bizarre nuclear cellularity and typia increase over grade as the metastatic potential, and also in the differentiated condrosarcoma, there are the coexistent of two morphology, so bimorphic lesion associated with a risk of metastasis almost of 70%. And what we do in this patient, a grade 1 condrosarcoma, you can watch on QRAT, and this is one of the cases presented at Rizzoli, but you should be careful because sometimes they relapse and they worsen in grade when they do that. When they are grade 2 and 3, wide resection is recommended, of course, for the potential metastatic burden. This is a 75-year-old male with a long history, which is quite typical of condrosarcoma, and this is the histological confirmation and resection. And then metastatic or non-resectable, so my field, what does the oncology do for the conventional condrosarcoma? Not much, I should admit, but this is changing over here. In 2012, Italiano reached out to collect all our combined cases treated with chemotherapy. This series is difficult to interpret because combine conventional with a diff with mesenchymal, but it shows that several drugs, including doxorubicin and gemcitabine and ifosfamide, were used in this population, and that the 6-month PFS was quite satisfactory, 56%, with a 2-year overall survival for patient overall 37%. Again, very difficult to consider this data in heterogeneous population such this, but combined approach seems better overall. And mesenchymal and the differentiated chondrosarcoma seems to benefit from conventional chondrosarcoma, conventional chemotherapy more than conventional chondrosarcoma. So this is similar to the data of the Birmingham group reported in 2007. And these are the newer treatment. I unlikely did the evozatinib study because imatinib was studied by the Italian sarcoma group in the past, but not much activity in terms of dimensional response. And while the evozatinib is going to be investigated in a phase 2 controlled trial. The evozatinib is a drug approved already for leukemia in EDH1 muted patient. In the small experience, 21 IDH1 mutated conventional chondrosarcoma underwent treatment, and the study was reported by Bill Tepp in 2020. Also, our friend Jonathan Trant included several patients. No objective responses reported, but there were some tumor shrinkage. The toxicity grade 3 was not bad, so a treatment that we can deliver to our patient. And the author concluded that for a phase 1 experience, this is a positive experience with some of the patient on treatment for more than 2.5 year. The worst aspect is that concurrent mutations were not predictive or were not there, and the translational samples also for the sponsored trial was limited. Another promising approach is that receptor 5, again, only for conventional chondrosarcoma, only phase 1 data for now available. This Imbrix 109 is interesting because it's a third-generation tetravalent agonist that targets this pro-apoptotic target. The dose was identified at 3 milligram per kilo, again, not incredible toxicities. Some bilirubin increase was observed, but overall well tolerated. And we have to be very careful that the patient has no hepatic comorbidity for this kind of treatment. The important things of this agent that dimensional responses were observed, and also the mean growth modulation index is positive. The phase 2 study is now ongoing and will seek for activity in a larger cohort for eventually approve a drug in the setting of conventional condrosarcoma. This will be the first time, so we are very eager to see these results. And last, the differentiated condrosarcoma. I'm very glad to have some time to discuss with you of this histotype. The first series from the Birmingham group included more than 300 cases, 21% metastatic at diagnosis, 30% pathological fracture, and very poor overall survival. In 2006, Dr. Stas and Dr. Bertoni reviewed also our series dating back into 1970 to 2003, and the survival at 5 years is around 20%, and also here 20% of the patient metastatic at diagnosis. The importance of this paper is that they reviewed all the radiologists to look at the morphic appearance and also the component, the differentiated component. So, as you can see, most of the patients did differentiate in osteosarcoma, high-grade tumors, but there are anecdotal cases also, for example, of rhabdomyosarcoma. And the implication of this histological classification on treatment is not available. Most of these patients underwent surgery, and 31 underwent an amputation. Chemotherapy was used in 25 patients. And importantly, they also measured the differentiated component. So when the differentiated component is more than 50%, the survival seems worse. So also this feature should be considered. But the 1 million question for the differentiated chondrosarcoma is, okay, they differentiate in osteosarcoma, but should we be giving them chemotherapy? They are usually old patients. The disease is usually very big. And the SER database was searched for this question, 188 cases by the Seattle group, Dr. Kramer-Lee. And the response was no, 25% overall survival still, both chemo, yes, chemo, no. But we always say that SEER evidence is quite weak, and I'm very glad to present the Eurobos trial again. Yesterday we analyzed the data of the rare tumor cohort. This is the DIF cohort. So 57 patients were prospectively enrolled, 41 to 65. Chemotherapy was given at lower doses and, when possible, combined as in this scheme. And also, some patients received chemotherapy neoadjuvant, and in case of histologic response inferior to 50%, the threshold for ordered patients were also given methotrexate high dose. And someone did surgery up front. So this is the results. I think this is very good results, and I'm going to discuss with the Birmingham group in January to the BOOM project. 5-year overall survival, 39%, and reaches almost 50 in the patient that undergo surgical complete remission. So in such a difficult disease, chemotherapy, similarly to the one of osteosarcoma, should be used. Mesenchymal chondrosarcoma, we have the old study from Dr. Cesari from my department. I put her photo because I see her every morning. And she collected 27 cases treated over a year, and they were given chemo, any type of chemo, like for Ewing, trioxio, to soft tissue, just to underscore that we didn't know what to do in this patient, but patient did not receiving chemo, which did badly. So now we, even for very small mesenchymal condrosarcoma, we use a Ewing-like approach. So chemotherapy also in the localized setting. To conclude, J1 localized curettage, J2 to 3, grade 2 to 3 conventional chondrosarcoma, wide resection, and of course, all these treatments should be discussed based on symptom and radiologic appearance in the multidisciplinary team. And then when the metastases appear or the disease is locally advanced, resectability should be always pursued by surgery and also stereotactic or other local technique. When the disease is advanced, we can choose among wait and see, chemotherapy, imatinib or regorafenib, evozetinib, and Imbrix 109 when trial are available. And for the differentiated localized and metastatic chondrosarcoma, I think that the Eurobos data are solid enough to and convincing to use Eurobos-like approach. So adriamycin, cisplatin, and ifosfamide at reduces dose considering the older age, and of course with some caution in patient older than 60. And I really thank you for your attention, and I thank all my colleagues back at Rizzoli for the work done in chondrosarcoma over all these years, in particular Prof. Bertoni, Alberghini, and our pathologist. Thank you.
Well, if you agree, I would like to continue with the next speakers, and then at the end we can make some comments or questions. So we continue with Marcos. Zapata is coming from Colombia, and we were talking about giant cell tumor.
Bueno, primero solo palabras de agradecimiento por la invitación. For me, it's a great pleasure to perform a talk after Dr. Palmerini. Sorry, the talk will be in Spanish, but the slides are in English. Me invitaron a hablar sobre si existe algún papel sobre el manejo perioperatorio en tumores de células gigantes, mi conflicto de interés, nada en particular. Y lo que quiero es que ustedes lleguen a la conclusión como si estuviéramos diseñando un ensayo clínico, ¿cierto? O sea, qué pacientes pudiéramos escoger, cuál sería la intervención y más o menos qué quisiéramos medir. Primero, entender que no todos los pacientes con tumores de células gigantes localizados son lo mismo. Cuando un paciente se presenta con dolor, es muy probable que estemos ante una enfermedad localizada en el hueso y probablemente resecable. Cuando un paciente se presenta con una masa de tejidos blandos, es más probable que biológicamente sea más agresivo y a la vez tenga compromiso de órganos vecinos o de estructuras vecinas que puedan hacer la resección un poco más difícil. Tener localización donde la resección sea más difícil, como pasa, por ejemplo, en la columna o en la pelvis, puede favorecer la recurrencia. Entre más difícil sea el paciente llevar una cirugía de R0, inclusive puede ser una enfermedad inoperable, que es completamente diferente a irresecable. Inoperable es que inclusive las cirugías ablativas o en bloque no puedan resecar todo el tumor, y la resecabilidad, digamos, si pudiera variar a través del tratamiento y el tiempo. Un factor muy importante para definir la recurrencia es aquellos pacientes que pudieran desencadenar enfermedad metastásica. Desgraciadamente no tenemos como la escala predictiva de metástasis, pero sí tenemos algunos subgrupos que se asocian más a metástasis. Uno de ellos, la enfermedad recurrente, la enfermedad irresecable, pero particularmente en los reportes observacionales es la enfermedad de radiodistal la que más consistentemente se ha reportado como enfermedad avanzada. Segundo factor para tener presente, ¿qué tipo de cirugía va a recibir el paciente? Si la cirugía es una cirugía en bloque ablativa, son los de menores tasas de recurrencia, menores del 5%, pero si la cirugía no recomendable sería una cirugía intralesional sin adyuvancia, las recurrencias pueden ser tan altas como el 60%, que es la línea azul hacia abajo. Lo que consideramos, digamos, estándar como una terapia de manejo con salvamento de extremidad son las terapias con curetaje y uso de cualquier tipo de adyuvante local. Ninguno ha probado ser superior a otro. O sea, los tratamientos adyuvantes locales hay que usarlos, cual probablemente en el que el centro tenga mayor experiencia. Hay un punto que siempre lo tenemos que tener presente cuando nos enfrentamos ante un tumor de células gigantes, sobre todo cuando es recurrente. Cuando es recurrente es el que más se asocia a una transformación maligna o sarcomatosa. Obviamente la radioterapia no la estamos usando en contexto de una enfermedad operable, o sea, sí se asocia más la transformación maligna cuando se ha usado radioterapia, pero no sería nuestro contexto clínico. Y en la enfermedad primaria en realidad es una patología de presentación realmente infrecuente, menor del 1%, y habitualmente lo sospechamos cuando tenemos gran masa en tejidos blandos, pero mi invitación es que cuando tengan esta enfermedad voluminosa de manera primaria, siempre pensemos en un diagnóstico diferencial. Ya el doctor Alberto Riggi más temprano nos mostró que puede haber utilidad en encontrar la mutación de la variante de la histona 3,3. Es altamente específico y sabemos que el condroblastoma lo puede presentar como patología benigna, pero cuando nos enfrentamos ante una sospecha de patología maligna, el osteosarcoma de células claras puede tener ausencia de la histona 3,3. O sea, si tenemos ausencia de esta mutación, apoya más que sea algo maligno. Su presencia, ya nos lo mostraba Alberto, también se puede presentar en algunos tipos de osteosarcoma. Lo siguiente, ¿qué tipo de intervención iríamos a utilizar? Recuerda que tenemos dos células, una célula que es la realmente maligna, que es la célula mononuclear. La célula multinuclear en realidad es una célula efectora, y lo que se ha descrito principalmente ha sido el uso de medicamentos como bifosfonatos y el denosumab. Les traigo este metaanálisis de los orientales en China, principalmente en Shanghái. Desde el 2007, ellos de manera estándar consideraron a todos los tumores resecables usar ácido zoledrónico, ¿de acuerdo? Y en este metaanálisis, principalmente, como está resaltado en rojo, de series de casos de ellos, principalmente de tumores de la espina, conocemos la gran frecuencia de presentación de ese tipo de enfermedad en China. Utilizaron ácido zoledrónico con solamente una dosis prequirúrgica y la utilizaron por 2 años, y ellos en su serie de casos demuestran una mejoría en la recurrencia, solamente llegando alrededor del 20%. Los franceses también hicieron su ensayo clínico con ácido zoledrónico. Pues traigo uno de otras series que hay, pero ellos utilizaron en pacientes operables con un esquema corto de uso de ácido zoledrónico unas recurrencias de alrededor del 20%. El primer reporte de denosumab incluyó pacientes recurrentes pero resecables, y nos vamos a enfocar en este grupo de pacientes. Interesante del estudio inicial de denosumab es que utilizaron unos criterios de respuesta histológica adicional a los criterios de imagen, y era la disminución de más del 90% de las células gigantes, o cuando las células gigantes eran muy pocas al inicio, la desaparición completa de la enfermedad. ¿Pero qué se encontró? Que de los seis que eran resecables, probablemente se operaron todos, pero al final terminaron siendo 7 pacientes resecables. O sea, probablemente alguno de los que se había considerado inicialmente irresecables terminó siendo resecable. Todas las muestras de histología que se pudieron analizar para evaluar la respuesta tuvieron cambios de respuesta. Y lo otro es que todos tuvieron respuesta por imagen, e inclusive en aquellos pacientes que se les pudo realizar PET scan tuvieron respuesta metabólica completa. ¿Qué es respuesta histológica en tumor de células gigantes? Pues este fue el definido en el estudio, que era la desaparición de células gigantes. Para mí es simplemente una muestra de prueba de concepto, o sea que está funcionando el denosumab. Pero recuerden que la célula tumoral en realidad es la célula mononuclear. Entonces, probablemente, y es una hipótesis, lo que pudiera explicar las recaídas después del uso del denosumab sean esas células mononucleares que quedaron embebidas en esa matriz osteoide o en la matriz en el área de hueso formado en la patología final. Entonces, probablemente no sea un buen marcador para determinar si el denosumab está funcionando, pero como entender su actividad antitumoral, probablemente falte algo más. Luego, en la última publicación de todas las cohortes que recibieron denosumab, y enfocándonos exclusivamente en aquellos pacientes que recibieron denosumab teniendo una enfermedad operable, pues como ustedes ven en la curva de hacia arriba, obviamente los pacientes que eran operables fueron los de mayor respuesta. Claro, al tener una enfermedad de menor volumen, probablemente la respuesta era mayor. Pero un dato interesante de este estudio es que aquellos pacientes que estaban planeados para cirugía, el 72% no se operaron, ¿cierto? O sea, de 100 pacientes que previos al uso del denosumab estaban planeados para recibir manejo quirúrgico, 72 no terminaron siendo operados. Y para mí, por eso explica que en el seguimiento a largo plazo las recaídas eran del 40%, muy similar a lo que ocurre en los datos observacionales publicados. Probablemente pudo influir que estos pacientes que eran operables no terminaron siendo operados. Y ya hablando de desenlaces de seguridad, en realidad solamente se presentó 2% de osteonecrosis de mandíbula, entendiendo que en toda la cohorte que recibió denosumab, tanto operables como no operables, tuvieron terapias que inclusive que duraron hasta 20 meses. Los pacientes que presentaron, por ejemplo, osteonecrosis de mandíbula, tenían habitualmente factores de riesgo que ya conocemos para osteonecrosis de mandíbula. Inclusive habían pacientes que habían recibido denosumab. Y en toda la cohorte, incluidos los operables y los no operables, solamente 5 pacientes presentaron transformación maligna, principalmente los pacientes con enfermedad irresecable o no resecable. ¿De acuerdo? Entonces, ¿cómo traer esto para el próximo lunes? ¿Para qué hacer con el próximo paciente? Les traigo lo que me ha tocado en los pacientes de la última semana. 25 años, un hombre, trabaja instalando redes de energía. Ya de por sí, nadie va a pensar en una cirugía ablativa que lo pudiera curar, pero ya sabemos de qué trabaja a los 25 años. Le encontraron tumor de células gigantes en tibia proximal. Obviamente la cirugía que le planeaban era poner una prótesis de rodilla. No les traigo la foto de antes del tratamiento porque quiero que vean la foto después del tratamiento. Y si ustedes ven ese anillo esclerótico que está debajo de los platillos tibiales, probablemente ese anillo sea lo único que puede salvar a este paciente de terminar con una prótesis. Nosotros lo discutimos hace 3 semanas en nuestro grupo multidisciplinario y estas fueron las propuestas que existieron. 1, igual, vaya para prótesis. 2, continuemos más tratamiento con denosumab. O 3, vamos a hacer la cirugía, en este momento una cirugía intentando salvar la extremidad. Algo interesante, entre más tiempo un paciente se exponga al denosumab, es más probable que en este anillo esclerótico queden ocultas enfermedades, células neoplásicas que pudieran explicar la recurrencia. O sea, entre más tiempo podamos exponer el paciente al denosumab, este anillo esclerótico que se forma ahí puede ocultarnos células que puedan llevarlo a recurrencia. Nosotros tomamos la decisión de ir a cirugía ahora mismo. Ahora este otro paciente, 19 años, tenía dolor en la mano y, como ven, un gran componente de tejidos blandos en la masa. Tuvo un trauma local después de estar montando bicicleta y llegó con mayor edema en la mano. Definimos empezarle denosumab. A los 2 meses de denosumab, el paciente ya podía hacer abducción del dedo. El dolor se le quitó completamente. Eso ya lo había reportado el doctor Javier Martín en el análisis interino del estudio de denosumab. Nosotros decidimos darle 1 año de tratamiento porque tenía gran componente de tejidos blandos y obviamente es una secuencia de imagen completamente diferente, pero quería mostrarles que ya los bordes se pueden establecer. Este paciente lo comentamos en la junta multidisciplinaria y si bien es probable que pueda perder el primer dedo, digamos, no, la cirugía va a ser menor que hacer una amputación completa de la mano. Pero bueno, no todo es color de rosa. Este es un caso que pasó a principio de año, 26 años, tenía dolor crónico en la rodilla. Le hicieron una biopsia, un tumor de células gigantes sin componente maligno y le hicieron una cirugía de salvamento de extremidad normal con su manejo adyuvante local. En el 2022 tuvo una recurrencia local confirmada como un tumor de células gigantes y tenía varios nódulos pulmonares. En particular, el superior se le sacó, el que está hacia arriba, y seguía siendo un tumor de células gigantes. Le empezamos denosumab. A los 3 meses después llega con las imágenes de revaloración y llega con esta enfermedad. Empezamos adriamicina más cisplatino y falleció luego de 2 ciclos. O sea, esto es lo que quisiéramos poder predecir o determinar en tumores de células gigantes, que si bien es un tumor que lo consideramos maligno con algo de potencial benigno con algo de potencial maligno, pues aquí vemos un resultado de un caso triste. Entonces, como conclusiones, primero definamos un grupo de riesgo. Si vamos a hacer un manejo perioperatorio, adyuvante o no, el paciente debe ser llevado a la misma cirugía, ojalá planeada previo al tratamiento. pues yo creo que todavía no es seguro decir en un paciente operable que no se va a operar independiente de la respuesta al denosumab. Probablemente los de mayor riesgo sean los de radio, los de espina, pues que puedan ser operados, o pelvis. El tratamiento importa, definitivamente todos los pacientes que van a un tratamiento neoadyuvante, que sería mi preferencia, porque además voy a tener datos para saber qué pacientes pueden determinar un mayor riesgo de recaída o no. Los pacientes deben ser manejados por lo menos con curetaje y manejo adyuvante, cualquiera el que en su institución tenga experiencia o tenga disponible. Si está motivado para un tratamiento perioperatorio, primero tiene que ser con el cirujano y el patólogo y el radiólogo al lado, o sea, en grupos multidisciplinarios, que es como se debería tomar la conducta en ese tipo de casos. Yo prefiero el tratamiento neoadyuvante, más que el tratamiento adyuvante por toda la información que me pudiera dar. Yo quisiera tener en los criterios de respuesta, además de la ausencia de células gigantes, quisiera tener, por ejemplo, la ausencia de células mononucleares determinadas por la mutación de la histona 3, por ejemplo. Por ejemplo, sería una buena opción, tratando de buscar una enfermedad mínima residual. Yo prefiero denosumab, porque creo que tengo mayor plausibilidad biológica de respuesta. Si voy a considerar un tratamiento para mejorar los márgenes, como vimos en el joven inicial del tumor en tibia, yo prefiero ciclos cortos para evitar que la esclerosis me pueda, entre comillas, encapsular células tumorales que me puedan llevar a una recurrencia. Y si yo tengo un paciente con alto componente de tejidos blandos, como el niño de la mano, yo sí preferiría tratamientos prolongados que me puedan mejorar la respuesta en tejidos blandos. Yo creo que debemos seguir haciendo las mismas cirugías que se planeó antes de iniciar el tratamiento, en este caso neoadyuvante, porque yo creo que una cirugía menos agresiva definitivamente sí va de la mano con mayor tasa de recaídas. Todas las fotos que le mostré es de alrededor de mi ciudad, de Medellín. Este es un cuadro de Botero pintado en un muro de un edificio bailando tango, en un barrio muy clásico en Medellín que se llama Manrique, el barrio más tanguero de Colombia, donde pueden ir a bailar tango. Previamente vieron una palma de cera que se llama palm wax, por si la quieren buscar en Google. Ahí vive un pajarito que está en vía de extinción por la destrucción de esa palma. Y también vieron un guayacán rosado, que es un árbol que solamente florece y bota todas sus hojitas de colores. Muchas gracias. Faltaba la última slide, por favor. La última slide. Muchas gracias por todo.
Thank you, Michael. We don't dance tango. You now. Well, the next speaker is Bruna David. Bruna is a friend from Brazil. She lives in Italy and gained many experience in sarcoma. So, Bruna, with you.
Hi everyone, good morning. Thank you for the invitation. How can I pass it? Okay, these are my disclosures for this talk. So before talking about an synovial giant cell tumor, I would like to say the important things about sarcomas, because we are talking about translational research in this talk. So I think it's really important to highlight some quotes about sarcomas. They are rare, they are heterogeneous. The systemic and local treatment differs between histologies. We must highlight that, because one size does not fit all when you're talking about research and treatment of sarcomas. They can arise from any part of the body, include bone and soft tissues. And of course, if they are histologically different, they are also molecularly different. So I brought here a few examples about these new discoveries about molecular biology in sarcoma. And here we are talking about tenosynovial giant cell tumor with DCSF1 alteration. Before that, what's the ideal precision target in translational research? So first of all, the actionability of a biomarker should improve the clinical outcomes. Of course, evidence of effectiveness must be proved. We don't know if in sarcomas just talking about randomized controlled trials because we're talking about a rare disease, so we must fit different trial designs as adaptive ones. Of course, the surrogate endpoint can be used, but must be proved in further studies, also in post-approval real-life studies. And the risk-benefit assessment, also cost-effectiveness must be proved because nowadays everything's becoming too expensive and too modern and no one can afford for everything. So we must think also about it when you are thinking about new drugs. So is tenosynovial giant cell tumor the best example of translational and precision medicine in modern oncology? This is the title of the talk. And just talking quickly about the disease, it's a rare disease, more rare than the whole group of sarcomas, so it's a ultra-rare disease as the new classification. It's a non-malignant, but you can have this small group with the sarcomatous differentiation, and this one could be metastatic, but we're just talking about the part of the non-malignant part. There is a genetic translocation, which translates in overexpression of CSF1 factor, the colony stimulant factor 1. About 15% of the cells, they have these alterations. So it's not about that the whole environment of the tumor has the alteration, the molecular alteration, but it is translated in an environment inflammation. So macrophages and other inflammatory cells, they come to the tumor and the tumor becomes bigger because of this environment of inflammation. As I said, it's a rare disease. We have some data from United States and other piece of data of worldwide epidemiology, but for instance, in Brazil, I think it's the same in many, many other countries. We just don't have a register for sarcomas, and of course not for this specific disease. So the whole hair tumors in Brazil, they are classified as other locations, which is really sad because we just don't know about our reality. So going back for the clinical features, it's a long period of evolution. They could be intra or extra-articular, localized nodule as a painless mass, or a diffuse disease. The diffuse disease is our problem because most of the time it could not be operated. Diagnosis, the most important radiologic method is the MRI, but can also have the CT scan, but ideally MRI, but you don't know, that's not a reality for every system. The biopsy provides us the secure diagnosis, and you can see in the histology this inflammatory system. As I said, the surgery is the standard of care for the localized type. For the diffuse, of course, it's the first option, but sometimes not possible because the disease is too aggressive locally and you can operate, or sometimes the patient is operated many times, and in the end, the local morbidity is substantial, and you are talking about young patients. So it's important to say that also the economic impact of this disease is really important because sometimes a young patient with a family to sustain is incapable to work and to produce economically same. Radiation can be also an option of treatment, but still it's not a standard of treatment also because of the local morbidity. And when local therapy is not an option, you kind of panic because you just don't have active drugs approved for the disease until this moment. I must say that yes, we have pexidartinib approved just by FDA in the United States, but is in a black box sign because of the hepatotoxicity. I'll talk about this later, but it's important to say that worldwide you just don't have drugs for this disease. So talking about systemic treatment, we know that you have this alteration in the CSF1 production and receptors. So basically you have antibodies and TKIs against this pathway. So imatinib, most of us know about imatinib. Imatinib is a TKI. It's not specific for the CSF1 receptor, but it blocks the CSF1 receptor. In a retrospective study, we saw overall response rate about 30%, which is okay, but it's a retrospective study, and the high discontinuation rate in this trial was quite impressive. About 6% of patients left the treatment. We just don't know why, but it's not the number that you have, for instance, in GIST patients, which is about 15%. So it's a good question why these patients just quit the treatment. Same for nilotinib. Nilotinib is another TKI, not specific for CSF1 receptor, but with activity for this pathway. It was a Bayesian phase 2 trial, and with no response rate in this environment, so super sad results. Other antibodies, I would like to highlight this one, the last one here, AMB05X. The results were presented last year, these early results. It's really interesting because it's an intra-articular injection with no hepatotoxicity, like super manageable increase of liver enzymes, and with a response rate super interesting, about 4%, like it's a local therapy. So it's important to go on with this kind of options for these patients with just localized disease. Pexidartinib, the only one approved in just US, it was denied from EMA because of the hepatotoxicity. So nowadays in the United States, you can prescribe these, but you have to follow the risk evaluation mitigation strategy, which is a secure program from the government, and it has a black box warning. So the hepatotoxicity was really, really important for this drug. And the last information about this pathology is vimseltinib. It's another TKI also, with a more selective pathway for inhibition for CSF1 receptor. So vimseltinib had the final results, the preliminary results of the phase 3 trials, and the final results of the phase 2 trials published a few weeks ago. This is the phase 1 trial. As you can see here, the overall response rate was about 72%, which is really impressive. The phase 2 trial in the cohort A, which were patients without previous therapy for CSF1 specifically, the best overall response rate was about 6%, which is still impressive. And the motion study, the phase 3 against placebo. And here it's important to highlight that you have a ultra-rare disease with a randomized phase 3 trial, so international comparison is really important for these kinds of achievements. And you have impressive results about the overall response rate, more or less 56%, and also clinical improvement in pain, in range of movement, and patient-related improvement in quality of life, which is really important because, again, we are talking about young patients. So my conclusions for these talks, you must remember that sarcomas are rare and heterogeneous, so you must think about histotypes, and when it's possible, also, when you're talking about research, it's mandatory to think about also the molecular alteration because they could be the driver of new active drugs. Talking about just TGCT, the actionability of this target was proved. We have this evidence. The surrogate endpoint at the first sight was okay, but you need to prove in real-life trials or observation. And of course, the risk assessment was really okay for this vimseltinib drug because we didn't have cholestatic hepatotoxicity, but we need to see if it is cost-effective or not because it's not worth it to have a drug that you cannot afford for. So it's another discussion, I know, but you must think about this when you're talking about new drugs in any kind of disease, especially in rare disease that you know it's not a priority in many countries. My God. I'm trying to conclude. I would like to conclude with my soccer team win. Finally, after 15 years, the Libertadores in Rio, and we are really proud of that. And I would like to tell Nat to thank you.
So thank you for these final slides. I don't know if somebody hears Boca, but sorry. Okay, we continue. We invite to Laura Cantero, is a special oncologist from Paraguay, and this presented the clinical case to start the discussion.
Thank you. Morning. Good morning for everyone. I will present a case that it will be like deja vu. Spoiler, yeah. I have a case about a white male, 39 years old, without a personal or family history, that in January 2014 presents pain in the right knee of 2 months of evolution, and the MRI, we had a lytic lesion in the right femur. The size was 4.5 centimeters. The lesion was eccentric, well-defined, but not sclerotic margin. In the epiphysis and the cortical has destruction. The final diagnosis was giant cell tumor, benign, in the right femur, localized, and this case was reviewed at the reference center. So we want to know, what will you do now? Emanuela, do you want to talk about neoadjuvant therapy?
So in the study presented by Nikos, and he actually selected the class of resectable patient. So that study underscored which is important to keep the same indication. So if the surgeon indicates a resection, we should do a resection. So neoadjuvant anosma is not downgrade to curettage. So if it is resectable in a multidisciplinary discussion, it should be resected. Upfront surgery.
Okay.
Yeah. Yes, I agree. The first question, every first question is, what is the surgery planned? Okay? Is it en bloc surgery or is a conservative surgery? In this case, without soft tissue component, if the surgery is not in block surgery, you must to go with the surgery. If there are a lot of soft tissue component or maybe intraarticular, it's quite rare intraarticular disease, maybe you can consider neoadjuvant, but in this case, upfront surgery.
Okay.
Absolutely.
Quick question, because in your speaker you say it's different, the patient with pain and the patient with the bigger mass. But the bone fracture is a good prognosis to the relapse, and the pain is a symptom for the cortical bone broken. So what do you do with those patients with several pain, but we don't evidence the fracture for CT or
The amount of patients with only pain mainly don't have a soft tissue component. That is the real bad prognosis component of the disease, the soft tissue component. If only had pain, it's true, maybe could be a fracture, but the majority of patients with only pain don't have fracture, only the insulated bone component. I don't know if you agree with me.
Yeah, I mean,
Thank you.
I agree. Again, if there is a pathological fracture, sometimes if it is infiltration in the surrounding soft tissue might be an indication, but also for practical reason might be considered by the surgeon an opportunity to operate. So it really depends on the doability of limb salvage with good result.
Okay. This patient was treated with curettage, phenol, and surgical semen. Was performed by an oncology surgeon. And then about local relapse. He has a local relapse in March 2022. The biopsy was the same disease, GCT benign, and the treatment was against surgery.
Yes, something about in this moment. When you have a local relapse, is the best predictor of systemic relapse. Please do a CT scan of the lungs, always with
no metastatic.
Okay,
No,
but it's advice for you.
Yeah.
If you have local relapse, always do you have to rule out the lung recurrence. And maybe, because in the study of the cohort with recurrent disease are included this kind of patient was surgery candidate, but is a recurrent disease. You could, maybe the time between the initial surgery and the relapse is often about 2 years, around 2 years the relapse, or is a late recurrence. I don't know, but it could change the option of systemic treatment. Do you agree with me?
Yeah, we in similar cases, a different location at relapse, we also in some cases underwent continuous denosumab, just denosumab and no surgery because of the limitation of reoperate on a young patient.
Okay, this patient he didn't do denosumab. Then in October, just now, October 2023, we find multiple pulmonary relapse, and the lesion of the biopsy of the lesion finds histological finding suggestive of malignant neoplasms. Only like this. In this case, I want to hear something about Alberto. Can you comment something?
Malignant transformation from giant cell tumor of bone, but I think
Yeah.
So, yes, first of all, is important to confirm at the beginning the giant cell tumor with H3F3A, and usually we might consider that in rare cases giant cell tumor of bone, also benign, so-called benign, can give a metastasis, but in these cases was more confident with malignant transformation in giant cell tumor of bone. You might consider that in general the malignant transformation we can observe it in 2 or 3% of all giant cell tumor of bones. This one is not in my opinion, is a high percentage. In particular, you have a primary transformation that was a malignant at the beginning, and we have a problem to the sampling of the tumor. And the most frequent is the secondary transformation. I mean, after treatment or after multiple recurrence, and the tumor became a malignant giant cell tumor of bone. Another important point that I would like to give to the audience is that the WHO distinguishes low-grade and high-grade malignancy in giant cell tumor according to the morphological features, the presence of atypia, amount of mitosis, and presence of necrosis. Just only to give the message that it's not so rare phenomenon and is necessary to think about it. In fact, the giant cell tumor is not considered a benign tumor, but is considered a locally aggressive tumor, rarely metastasized.
Okay. Yeah, it's only about the development. Are meds always a malignant transformation? Is the question?
Always, if lung nodule could be resected, must be resected. Even
not resected.
in non-malignant giant cell tumor. Always resection is the treatment of choice, always. All right, this is
case
not
not.
resectable. But I'm afraid, I have a question for you. When the last patient that I showed you in my slides was a rapid progressive lung disease. How I suspect that? I have 2 biopsies, one resection of nodule without malignant transformation. If I perform a PET, the PET CT scan don't help me to rule out the malignant or the benign. How I suspect that is that we need chemo or start denosumab as is in this case?
I think there are several different clinical scenarios. Usually, these kind of malignant transformation do not respond to denosumab and also to standard chemotherapy, but of course you attempt any line of chemotherapy. This year we had a very unusual case, diagnosis with malignant transformation after 9 years of denosumab and 2 years of drug holiday. And I did give the patient one denosumab shot before the biopsy, and the disease responded very well. So I called Gambarotti, was like, are you sure it is a malignant transformation? Of course I am sure. But probably I think this kind of patient might be more in the low grade malignant, and maybe your super high, like grade 6 malignant. Probably in the future we will classify it more deeply, but of course specific drugs are really needed for this poor patient.
Just a question. You said that you usually resect everyone when they appear with lung mets up front, or you go first for denosumab and then to analyze the biological response?
For me, if I'm sure that it's a benign giant cell tumor, always upfront surgery in lung mets.
I disagree.
Okay, I perform after denosumab. Okay.
No, I think which really changed our paradigm. Of course, it's a multidisciplinary case-by-case discussion. And I remember the last case, a beautiful, handsome 2 meters basketball players. After 2 years, it's a tibial disease, lung mets, bilateral, not huge, but progressing. And then after 2 years, they were like, oh, doctor, what should we do? Operation, and then we don't know, radiation, and then the side effects, I cannot play basketball. And then we decided, just watch for Wakeful, and then we can re-challenge denosumab, and we'll see, hopefully, it will.
Okay, we don't have more time, so I will thank 3 or 4, Laura, Manuela, Maikos, and Bruna. Thank you.